Please welcome the moderator for our next panel, Veronica Combs.
Hello again, and welcome back from lunch. I was fairly healthy, although I confess I did miss the brownie. It wasn't there, and I probably didn't need it, but I still missed it a little bit anyway. I'm really excited about this panel because we have the whole gamut of experience and perspective, from doctors to patients to advocates to people running online review forums. So we'll go around, start over here, and everyone's going to introduce themselves. We'll talk for about 20 minutes, and then there are volunteers passing out pads of paper and pencils. We'd like to get more audience questions in this time. You all have been asking really great questions, and that's my favorite part of every event is audience questions. So if you have a specific question, write it down, and you can also tweet them to me, to MedCity News, or to me, and put MC Engage on it, and we can ask those as well. So, do you want to introduce yourself?
I'm Suzanne Mintz. I am the co-founder and CEO Emeritus of the Caregiver Action Network, formerly the National Family Caregivers Association, and we are local to the DC metro area.
I'm Adrienne Boissy. I'm a neurologist at the Cleveland Clinic. I'm the medical director of the Center for Excellence in Healthcare Communication, so I teach people how to talk to other people. And I'm also an ethicist, and I'm charged with leading many of the experience efforts at the Cleveland Clinic.
I'm Sarah Kucharski. I am CEO, chairman, and founder of FMD Chat, which is a peer-to-peer support group for those affected by the rare disease fibromuscular dysplasia. I'm also known as Afternoon Napper, so if you've seen me in the tweet stream, hi. I am not actually a cartoon, but I am an advocate who's working within the healthcare system just for my own needs and the needs of my fellow patients, and my full-time regular job is also as a magazine editor.
Hi, I'm Royce Laux, and I am the general manager of Angie's List's health and wellness vertical. So that means I have product responsibility as well as consumer and provider engagement responsibility for all our health product online, which are the reviews on doctors and dentists and the like. I've had a unique experience of being able to work in the healthcare industry in a couple of different sectors in the past. So I bring some broad experience, but certainly today the consumer experience as we see it on Angie's List with our members.
We've talked a lot today and also in many other contexts about patients becoming consumers, and I think I heard someone going down to lunch talking about it, and it sounded like that person didn't think it was a good thing, and I can see sort of good and bad. Part of becoming consumer, changing from patient to consumer, is language. We've talked a lot about language today, and yesterday, which is interesting to me because I'm a word person, but language does have a lot of impact when you're trying to communicate with someone and get a message that you can both agree on. I wanted Sarah to talk a little bit about language and how it affects communication, good words, bad words, words we need to get rid of.
Well, some of the language that's inherently involved in the patient engagement conversation is language that can be construed as a bit pejorative to patients. It's language that is talking about doing things to us rather than with us, about engaging us, activating us, these things that make us sound very much like robots that need some sort of rebooting sequence. Whereas really, the key part of patient engagement is based on relationships and building that relationship between the patient and the doctor so that there's more of an openness, there's more of a dialogue, and that relationship is one of trust, empathy, and compassion to actually build the engagement between the two.
You know, I'm really glad you said that and used the word pejorative. I completely agree with you. Patient activation just makes my spine quiver. If you go to the dictionary, it doesn't even relate to people. You can't activate a person. And I know there's no intention to be pejorative, you know, when researchers and physicians and academicians come up with these terms, but it shows that they're not understanding things from the human side. And even the term patient, you're only a patient when you are in that healthcare setting. And from the family caregiver perspective, talking to us about the patient, well, to us they're not patients. Their mom, their husband, their kid, their whatever. And so we really need to recognize that we live in two different worlds. And for those people on the consumer side, who are patients or caregivers, what we're looking for is a quality of life. It's not about a specific measurement. You don't look at, I mean, that might be the way towards what you want, but especially when you're dealing with chronic conditions, the word cure doesn't even come into it. So it's about how does one manage symptoms? How does one plan for an unknown future? And so how is the broad community, which needs to go beyond healthcare, because persons with chronic conditions need goods and services that are not part of healthcare delivery per se, and how do we integrate that so that we educate providers coming down the pike and pay for care that really is truly holistic when you're dealing with a chronic population.
At MedCity News, we try not to write like the newspapers. We try not to write like the really, forgive me for anyone who writes for these, but any of the stuffy journals. We try to write in more common language so that everyone can understand what we're talking about. But it's so easy to fall back on jargon because it's shorthand. It's much easier to write this one jargony word than a longer sentence. So I'm sure you've helped doctors try to communicate differently and use different words. Could you talk about that?
Sure. So I did it just yesterday, and the many themes that come up about training physicians about how to communicate, we call it more effectively, because even words like you're a good or a bad communicator are very judgmental and imply that the person is bad. And if you know any physicians, they're very sensitive. So in order to be sensitive to that, we need to better understand what language is effective at doing what we're hoping it will do, and what language is less effective at doing that. So it doesn't become about the person, it becomes about the words they're choosing, the language they're using to achieve a certain goal. And so even that framing of some things you're doing are effective and some things are less effective is really, really important to get some buy-in from physicians as opposed to judgment.
Are there any examples you could share of helping someone make a change from this word to that word, or anything more specific to?
Well, the classic example for physicians is a patient says, so if I'm the doctor and you're the patient and you come in and you say, well, I've been really worried about the pain in my left leg. I'm wondering what's going on there. And the doctor says, well, your MRI looks normal. And then the patient says, well, yesterday I was out and I was playing with my children, and I'm really worried that my left leg isn't going to keep up. I'm going to be impeded in my ability to play with my children because of my left leg. And the doctor says, So I went over your labs, and so for physicians, we've trained about 1,000 physicians, which is almost a third of our entire staff population of physicians in communication skills. And physicians, if you ask them, I've never heard a physician say, I will say to a physician, what was your intention there in that conversation? And the physician will never say, oh, I was hoping to be a jerk. Or I was hoping I could miss all of the emotional cues that the patient was dropping. But nonetheless, that's exactly what happens. And so when you rewind a physician and say, they are messaging emotional cues to you, and it doesn't matter if you teach them the right words to say. If they miss the cue, It doesn't matter whether they're supposed to say, oh, I'm sorry you're sad, or oh, I see you're scared, because they're still not hearing the cue. So part of the training really is not only to hear the cue, but then to evolve the language.
So sort of what I hear you saying, or what you really seem to be saying, or
This skill of reflective listening. So when somebody says, gosh, I'm really scared, acknowledging verbally not only the emotion you're hearing, but the content of what you're hearing is a underestimated skill set. But again, we all have agendas in those conversations that we're eager to get to.
So one of the things that's really interesting listening to us talk about language and really getting deep specifically into certain words is, I think if we pull that up a level, what we see at Angie's list is that one of the two most important things in choosing a provider is communication. And so language is certainly a piece of that. And then when we look at the reviews coming in on our health providers on Angie's list, unfortunately, the area where we see the most C, D, and F grades on an attribute level is communication. And now I'll say overall the grades are very high on Angie's list, much more A, B in grades even in communication than anything else. But that seems to be the one attribute where there is a disconnect within healthcare between that consumer, that healthcare consumer, and in the providers or the healthcare system on the whole. So communication can mean a lot more than language, but certainly is highly, highly important to that patient experience.
Andrea talked about teaching doctors how to communicate effectively. We've got a program called Communicating Effectively with Healthcare Professionals. So it's from the other side, because there's a responsibility on the part of patients and families to be able to report symptoms in a way that a doctor can. It doesn't mean we have to use medical language, but to know that, with pain, you talk about a scale of 1 to 10 or whatever. There are things that we can learn to make the process easier. I mean, even things like understanding how the doctor's office works. So that when you call and you want to speak to somebody, at least you're calling at a time where they're more likely to be available. So there are all kinds of educational issues that patients and families can be taught to deal with. But at this point, there really isn't any formal education on how to get the most out of your experience. And, if you're a casual visitor to the doctor's office, you've got an annual visit or whatnot, it doesn't matter. But when you're talking about people who are so involved with the system, either because they're ill or they're disabled and they have, other underlying chronic situations, it is imperative. And, providers go to school. We learn on our own. Not good.
You mentioned when we talked before about perhaps about invisibility and about how lots of, honestly, I know there are fathers and sons who care for their elderly parents, but lots of women's work is kind of invisible. It just gets done. Just magically, it gets done. So you talked about caregivers appearing in the medical record, or maybe part of, I know that's down the road, but still, I thought that was a very interesting idea.
It's, this is my big hot button at the moment. The first line of respect is to somebody have a name, to be mentioned somewhere. Well, we talk about family caregivers, but there's actually absolutely no record of our existence. And if we're going to provide really good care to persons with chronic conditions, most of whom have a family caregiver, it's about 80% of people who need long-term services and care get it from family. So this is the highest proportion, but we don't look at them as a dyad. And so if we are not listed as a member of the care team, and if you don't know what it is we do for John, or how long we've done it, or if we're also caring for 3 kids and our next neighbor, there's no way that you can help us be the best caregiver that we can be and help the profession at the same time as taking care of ourselves. So documenting family caregivers on medical records seems to us as the first thing we have to do, and we're actually planning a meeting for early fall to figure out what are the best ways to get payers and providers to really want to do this. Because it may be mandated in Meaningful Use 3, but that's very different from, really having one want to have it, and then of course getting the IT systems to have all the places for the right information.
I'd like to go back to this issue of responsibility, which I think is a great word that you bring up, and the nuances of communication, of what was happening when you, Adrienne, were pretending to be the patient and talk about, well, I'm really worried about these things happening. And it's not necessarily that the patient is complaining about the left leg. And if we can get them to even complain specifically about the left leg rather than my left leg hurts, we can get them down to the specifics. Patients having those responsibilities to be the effective communicator in return, because with the effective communication on the patient end, they're reaching out and trying to engage the provider. And the more effective that both of those people can be, and patients having that exactly responsibility of that communication and putting it on themselves to be engaged, the better the care is going to be, the better doctor you can be when I can be more specific about exactly what it is that is hurting or that I need or that I'm worried about. And then in relation to caregiving, whether or not my concerns are, I am worried that my caregiver is going to be able to help me with these things so that you can further include that caregiver in the plan.
I think I appreciate the point about sort of patients learning how to be more effective communicators. But I also think, there's data certainly that shows that patients' chief complaint is not the thing they're most worried about. That they won't bring up the thing they're most worried about if the physician doesn't create an atmosphere of safety. And I worry a little bit that if we are to embrace patient responsibility as learning how to communicate a pain scale, that even then we may miss at times. So I'll give you a brief example. It's a story I've shared in one other setting, and I'm going to keep it very brief. But I think it speaks to that. So there was a patient in the hospital who was recently admitted. I had my gaggle of residents behind me, and we were standing outside of the room trying to figure out what was going on. It was on the inpatient service, and the patient was complaining of pain, had been transferred in from an outside hospital, had been in the hospital multiple times. We threw every drug you could possibly imagine at her. We probably spent $1 million worth of medication on her. Transferred in emergently, 2 a.m. To our hospital for headaches that had been going on for 3 years, which of course I'm going to fix. And so we're talking outside. My entire team is fairly frustrated. She's narcotic seeking and all these other components, right? So my team is clearly frustrated. There's a clearly low level of empathy going on. And I walk into the room and I say to the woman, so tell me a little bit about yourself. And she starts telling me about her headaches. And I said, I don't want to know about the headaches. I just want to know about you. Tell me about your life a little bit. She says, well, I'm a pharmacy tech. I said, oh, that's very interesting. And then she says, I live at home with my parents, but my parents don't believe there's anything wrong with me. And I said, well, that's very interesting too. And so I said, this has been going on for a long time for you. What do you think is going on? And she said, well, I think I either have parasites or MS. I was like, wow, well, that's something I can sort those out. And then I said, how has this impacted you? And she said, well, I haven't been able to work and it's really impacting my relationship with my family. And I said, well, what are you hoping we can do about it? And she said, well, I don't think you're going to cure my pain. And I was like, yes, that is correct. And I said, I share your concern. I'm really concerned that I'm not going to be able to fix your pain. We haven't been able to manage it. And I said, in my process of talking to her, I said, is there any history of abuse? And she said, well, I was raped as a teenager. And then I'm examining her, and she has this enormous scar down her arm and some at her wrist, and turns out she was a cutter, and she had set herself on fire.
Oh my goodness. That's a lot.
And I don't, although that's a shocking story, my point about it is, had she just gone into the dialogue about pain and severity and where it is, I would have missed the point. And the point was that she was suffering in a way that we needed to address that had nothing to do with headaches. And it was a lesson, certainly for me, about these are communication skills. We need to be able to create a place where these things, where people share these stories that they probably don't share with anybody else. And we can do that with very concrete skills. So I see, both sides, I think, are really, really important there.
Well,
I'd like you to be my husband's neurologist.
Come on up.
One way you could be visible in the process, and you could provide feedback, is writing online reviews. And people can get pretty mean and pretty irrational online. I love the internet, but people get mad about parking when they go to the doctor, or they'll be mad that I didn't include the right picture with some article. It's very difficult, but it seems like on Angie's list there's ways that patients can do it right and doctors can respond right, maybe, to make it, because I cringe when I read some reviews, because I think, oh, gosh, I feel bad for the doctor, I feel bad for the patient who's angry.
Yeah.
What is there insights you can provide there?
Sure. I think there are a couple of things here. One thing is this isn't something to be afraid of. In fact, it's really great insight for healthcare providers into what people are talking about when it comes to their practice. We've always shared experiences with our neighbors, with our family members, and now there is a way for the system and the providers to actually have visibility into that sharing that's been happening kind of on the front porches and kitchen tables in the past. I think that the great news is there are ways that you can have quality information and you can encourage quality sharing online. We're quite fortunate at Angie's List in that the model we've developed is one where it's a subscription network, so consumers pay to join our service, and there's a sense of accountability that comes with that. We have lots of auditing that happens around the reviews, so people tend to be less emotional or irrational in their reviews and a lot more thoughtful and factual in their reviews. So you get something that is a little bit more indicative of an actual experience. I think the other thing that we've done, and there are some other review sites that are beginning to do this as well, is provide insight not just at the overall what was the grade of this experience level, but on some key attributes that matter to consumers. I think the pushback we got initially when Angie's List launched health reviews was more from industry associations being concerned than individual providers. Industry associations sometimes were worried that there would be a drug-seeking patient who then went online and put in an irrational negative review that was really unfair. And how would we guard against that for those good physicians that were doing the right thing? We've seen that's not the case. We really have seen that's not the case. Most people are going online to share their real experiences with a peer network, and peers are looking online to find what was the experience. And people that are searching for information are smart enough to be able to see, okay, I see a lot of A and B grades on communication. I see a lot of C grades on punctuality for this provider. I see a lot of A grades on bedside manner. I know what to expect now. If I choose this as my provider, I can expect I might want to bring a book because I could be in the waiting room for a little while, but I can have an overall good experience based on what other people's experiences have been. So that concern about is somebody who's not qualified providing information about clinical care when they aren't smart enough to do so is missing the point. What's happening is people are sharing experiential information that allows others to choose a provider that's going to best meet their personal needs in that particular therapeutic area. We've seen a lot of positive uptake over the last few years, and it's a self-perpetuating positive cycle. You go to find a good provider, you see providers with good grades, you choose a provider with good grades, you put in a review because you had a great experience, it's another good grade for that provider. It helps elevate customer service on the whole for those providers who are engaged or encourage the engagement of their patients.
Reviews are one source of information. I know, Sarah, health literacy is an issue for you, which obviously, if you don't understand what the doctor's saying, it's hard to follow his or her instructions. Are there online resources that have helped patients become more literate, or anything on that line that you'd like to talk about?
I like the mention of the peer-to-peer experiential, because in my patient community, that's a huge source of both emotional and medical support, because my patient community is very small. Fibromuscular dysplasia, for those of you who aren't familiar, which is most of you, it's a rare vascular disease, and my own diagnosis is of having a rare version of that rare vascular disease. So having a community of patients isn't something that I'm going to find in the general population. I'm not going to just bump into somebody. I have to actively seek these people out in an online forum. And that's one of the things that FMD Chat has done, is create this environment for the peer-to-peer experiential kind of exchanges. And having that communication between communication between patients gives them more freedom to actually talk about day-to-day life issues. You mentioned quality of life. That's a huge concern for us, because with the nature of the rare disease, there's not really a treatment. There's surgical management of vascular damage, but in terms of pain and headaches and these things that are affecting the patient population, turning to one another for support is what we rely on the most. And being able to compare notes with one another, and in a very quick manner, such that if it's 2 o'clock in the morning, we are an international community, and so somebody's still probably awake, and being able to say, I'm experiencing XYZ, has anyone else experienced XYZ? What did you do when you experienced XYZ? Because some of the things that are involved with the fibromuscular dysplasia diagnosis can be strokes, aneurysms, TIAs, things which I've all had. And so how are we able to provide any kind of support to these patients of saying, that's serious enough, I think you might want to call your doctor. Go ahead, go to the hospital, be wrong, and be at the hospital, and be safe, rather than be home and be dead. So.
In caregiving too, the peer-to-peer network is really important, because although there are more than 65 million family caregivers in the country, isolation is this huge factor that people think nobody else is experiencing or feeling or thinking what I'm thinking. So, somebody who's thinking, good God, I wish he was dead, think that it's terrible. But the point is that if you're thinking it, there are a million of other people thinking it as well, and it doesn't mean you really mean it. It's part of the whole emotional thing. And so be able to we have forums that people can go on and ask questions, and that bridges that sense of isolation. And another thing that we find is really important is telling stories. We've got a story project on the site, caregiveraction.org, where people can write what they're thinking and feeling and list 3 wishes. And you can read other people's stories as well, but there's something about those 3 wishes that tell you so much. I remember one where a woman said she just wanted to be able to go to church twice a month. It's like, and then there were a lot of things about finances, and what's not covered, but you get a really good picture of the situation by looking at those wishes. And people's story, you can't make this stuff up. It's unbelievable what some people live with. And I think for everybody else reading it, it's almost like, oh my God, aren't I lucky?
Do we have any questions? There's a mic. Any paper questions? If you all want to bring me the
Front
questions,
row.
I think this man at the edge here has a question. Thank you.
And this gentleman had a question, the one in the front row.
Yes. In you speaking about all the engagement when consumers want, you're talking about mainly communication. But another way of communicating is not verbal, but the experience that the patient has. And if you look at patients as consumers, you can look at other consumer models. For one thing, in the healthcare model, some of the fastest growing areas of healthcare right now are minute clinic and urgent care centers for primary care, because basically the model of the traditional practice is really where some of the roots of the problems are. It's not what they say once they get there. We created a chain of diabetes clinics, and we designed it without a waiting room. Now, when we told physicians and nurses that we weren't going to have a waiting room, they was like, break out in a rash. They was like, you can't do that. But to be truly efficient and have a completely streamlined process, no waiting room meant that we all had to be efficient in that streamlined workflow. Some areas of consumer type experience, you're never going to put a restaurant on the second floor because you know that 60% of your traffic flow is going to be eliminated if you go to the second floor. You want ground floor access. So all of these are the ways of creating a consumer experience that really haven't been introduced in healthcare environment. What are you seeing in some of those characteristics where maybe truly disruptive change in the structure of a practice, the location of a practice, free parking, things like that, beyond just the communication?
There's a fabulous place in Baltimore called the Kennedy Krieger Institute, which serves children with special needs, primarily spinal cord and orthopedic. And they also have this International Center for Spinal Cord Injury, which is how I know about it, because my husband has MS. And so he's been going there for about 5 years, twice a year, for about twice a week for 2 months, for these very intensive PT and OT sessions. And this whole facility, and they have this new building, has been designed with that patient population in mind. And so there is free valet parking. You don't have to go up ramps anywhere. It's either all level or there's an elevator. The corridors are wide enough for wheelchairs. The desk levels can accommodate wheelchairs. The thought process is about what is the experience that this child and this child's parent or parents or whoever are going to have walking through this physical space. And it makes a huge difference, because if you've got to fight the terrain, you're hardly in a position to come in there and be compliant.
I'd like to hold up the Cleveland Clinic as a fabulous model of doing very small things to change the patient experience to achieve customer satisfaction. I was fortunate to go to the vascular center there, and the little things that you immediately notice are like valet parking, that there are always people in, I believe they're red jackets, who stand out, who at any time, if you are lost, if you do not know where to go for your lab or whatever, they're there to answer the question. They're there to be your guide. Instead of what I always consider to be a great HIPAA violation, calling of names in the waiting room, they're pagers. If Chili's can pull it off, we've got this hospital system that when it's your time, your pager goes off, you go up to the counter, then they take you back. One of the things we talked about on Twitter earlier was also the Heart Center worked with Diane von Furstenberg to develop new gowns that are not going to show off your tush, and instead they're wrap style, which still provides all the access that the doctors need, but provide patients with a much higher level of dignity. And they're more comfortable, and I was fortunate to be able to wear one of these. And again, this isn't rocket science, but they're tiny measures to preserve patient dignity so that we're still people who have rights and needs to be considered, rather than pieces of meat to be shuffled through the system.
Well, and so the other thing that I think your question was leaning toward that maybe we haven't spent much time on here is we've discussed a lot of chronic conditions in the healthcare system and how it impacts that, 5 or 10% of the population that's really heavy users of the healthcare system. But we haven't spent a lot of time talking about sort of the rest of us, the 90% that seek episodic care or primary care, and how do we make that easier? And I think part of what we do moving forward is, rather than treating us as patients, it's healthcare consumers. These are the people that really are the leading edge of healthcare consumers, not the one who's been referred to 16 specialists and there's not a lot of choice in the matter, but the other 90% of the population who's really going to be making their own healthcare decisions in the next 5 and 10 years. I think most people aren't comfortable doing so today, but are going to have to get comfortable. And so where are they going for information? How are we providing that information? And then how are we making healthcare really consumer friendly so that they don't mind having to pay out of pocket and they don't skip an annual appointment just because it's inconvenient and expensive, but that they take it in stride and have a good experience, whether it's at a retail clinic because it's quick and easy and on the corner, or at a primary care practice where they can be serviced by a nurse practitioner. But I think there are a lot of opportunities here in these next couple of years for us to get things right for that large volume of people that really don't need minute-to-minute healthcare, but need sort of annual, now and then episodic care as a consumer more so than an everyday patient.
I'd like to pick up, you talked about people not minding to pay out of pocket, and I think that's fine, in terms of the occasional visits and, depending upon your own pocketbook. But getting back to the other population, it can be a huge issue, and there's actually a section in the Affordable Care Act that most people, I think, have not read. But what it is doing, it is raising the threshold for the medical deduction from 7.5% to 10%. And it goes into effect this year, except for seniors who get a couple of year reprieve. But most of the people who take that deduction are taking it because they got a real medical problem. And in fact, large portion of the population that's using the deduction counterintuitively are people who earn $20K or less. And so for them, the $500 difference is huge. And again, it's another one of my hot buttons, so that's why I picked up on it so I could share it with this audience. But again, it gets back to people's lives and how each individual, is going to react to different aspects of healthcare, and therefore what we have to do, for each of them individually.
One of our questions was for Adrienne, how has the Cleveland Clinic convinced people or helped people communicate empathy to consumers? What are some maybe more specific examples of your work or the clinic in general? I will say Dr. Cosgrove spoke at Datapalooza, and he said it took 6 years to get that gown designed, figured out, goes through the laundry okay, and implemented. So 6 years is a commitment for a gown, which is certainly very important, but he was surprised it took 6 years.
Well, I mean, just as an aside, there's nothing more flattering than a patient speaking to, recognizing changes that we've made. I really appreciate that you shared those, rather than me talk about them. So a couple things. So when I hear the word consumer, I bristle just a tiny bit in the sense that, healthcare is not, I'm just going to be transparent here. Healthcare to me is not the same as all other businesses, right? I mean, I've never met a patient that comes to see me who's like, Dr. Boissy, I'm so excited to see you today. I couldn't wait to get to the doctor's office. Or, when they come in through the ER and I see them in the hospital, nobody wants my service. Nobody actually wants to be there. And so it's, if you start at that point, even that in and of itself deserves some recognition. So when I open with patients in the hospital, I often say, I'm so sorry you're here. It is my first line, not "Hi, I'm Dr. Boissy," as though you expected to be at the hospital, but an acknowledgement that their experience, they don't want my service, and they really didn't want to be there.
I can see just a sigh of relief.
And how incredibly disruptive it is. And in addition to that, our consumers are emotionally tied to what you're doing, right? Illness means so many different things to different people. So it's not going to Target and buying diapers. I mean, that is not an emotional experience. It is
if you're buying adult diapers.
So it's so tied. They're so woven. So for me, as I try to think more specifically about how to answer that question, my approach with clinicians at the Cleveland Clinic has been, I've never had to convince them of why it's important. We have 30 years of data that talk about why communication skills are important for patient outcomes, compliance, adherence, physician satisfaction, patient satisfaction, engagement, trust, loyalty. So I don't even need to build the case. I don't need to build a case about communication skills. This is a part of what you bought into if you became a caregiver. And we call our doctors caregivers is a major shift. We call all healthcare providers caregivers. And so I also work very hard to say to physicians, a lot of it's about messaging. You are already doing a fantastic job communicating. You're probably doing the best that you can do. And you're probably pretty good. You have an expertise clinically that I don't want you to change. And yet we live in a different healthcare environment where now you need to do more things more effectively with less time, with exceptionally complex patients, as well as your garden variety or sort of your more common mainstream patient. And I need to be able to deliver a product in terms of communication skills that sets the caregiver up for success in whatever encounter. Whether that's needing to communicate effectively in a very brief period of time, whether that's developing a chronic, having a relationship evolve over time, whether that's acknowledging fears. There's all sorts of different needs that people have. And so for me, it's also about approaching the caregiver and modeling the same exact behaviors that I'm hoping they will provide to the patient. Because caregivers too, if I've been increasingly reflective on physician training and development, it's not a compassionate place. It's minutia focused. There's not plenty of opportunities right and left to process our own emotional experiences. And it's a very punitive environment. And then we unleash physicians on the population and we wonder why they're not compassionately caring right and left. And part of it is that hasn't been modeled to them in a long time. Residency training is very effective, I think, at squashing empathy out of providers. It's what it does.
Well, and as a patient, it's strange because sorry if this is too much information, but I had a miscarriage, and I was, whoa, I've never been through this. And I could tell my doctor was really uncomfortable too. And so I'm sitting there feeling bad for her and dealing with my own issues and thinking, man, it was just a very strange, I wanted to help her because she felt bad giving me this horrible news. And so patients have to live with the bad news or the confusing news, but doctors have to deliver it. And so it's a cliche to say it's all about the relationships, but...
Well, and I think one thing that's encouraging is that while we've talked a lot about communication sort of at a broad level and then also at a language level, when we look at our member reviews on Angie's list, bedside manner is one of the attributes you can review in addition to overall grade and other things. And bedside manner is usually very well scored. Most people really like their doctors and they really like that one-on-one interaction or that exam room experience with their provider. It seems to be that a lot of the challenges or the few challenges that may exist sometimes are in some of that wraparound that maybe the provider doesn't have a lot of insight into, or it may be, nurse communication or staff communication or billing or other things that sort of sour a healthcare experience that may have otherwise been great. But bedside manner tends to be one that is really highly rated. Generally, people like their doctors, and if they're in a serious disease state and they are critically ill, research we've done in a health system I worked for before said they'll give up a lot to have the best doctor then. Like, they'll put up with bad communication if they know they've got the best guy on the case. In which case there's an opportunity for the rest of that care team to help boost up that maybe one person on the care team who's a poor communicator, so that they can have sort of that best surgeon while still having a good experience.
Oh, just before, I appreciate you sharing that. I'm sorry that happened.
Thank you.
But it also highlights to me that there's a difference between sympathy, right? A physician feeling exactly what you're feeling, versus remaining curious about how you're feeling and trying to explore it with you without internalizing that. And for many clinicians too, we focus a lot, as a specific example of what we've done. So we train, there are two physicians who train a group of 10 physicians at a time. It's very intensive individual work, very specific on communication skills in different scenarios. And then we work through difficult communication challenges that they've had in real practice. And we offer that 8 times a month. All incoming staff physicians now have to go through that training, and then we've evolved the training into an advanced curriculum. So I'm happy to talk later about it. Another reflection is that physicians are very interested in fixing, right? We are fixers. We feel like that's what we do. That's how we heal. That's how we help. And it's a frustrating place when we can't always fix things. And oftentimes when you're hearing symptoms, I hear the physician's mind immediately start going, what am I going to do? What's the diagnosis? What am I thinking next? And they don't just sit there in the moment. And so engaging right in the moment without fixing is also something we work a lot on.
You wanted to say something, I think, Sarah?
Again, the Cleveland Clinic as an example, you guys have a video, an empathy video, that if you haven't seen it, Google it now, watch it. It's wonderfully dramatic in its illustrative point of everyone has a story. And if you don't think that everyone has a story, then you're not listening. Because that doctor, you don't know what she was feeling at that time. She's somebody too. And she could have been going through her own history, her family's history, and having a reaction to that and not knowing how to process that within the context of still being your doctor. And seeing that whole picture, that this relationship, this engagement, this empathy is, again, relationships. That's such an incredibly big piece of the puzzle. And so just when you're trying to engage a patient, open yourself up to listening, to imagining yourself as being that patient, to having their experiences. Michael Graves is a wonderful designer with a history in architecture who he ended up actually being paralyzed from the neck down after a disease, and suddenly found himself in a hospital room trying to interact, and be a patient with these, the horrible tray that they put over your bed, and the fact that the sink is here, but if you're in a wheelchair, you can only see from here up because it hasn't been designed for people in wheelchairs. And so try experiencing it. If you want to live 11 days in an open background, go for it, and see how that changes your perspective.
At Kaiser Permanente out in California, they have a big warehouse where they try different care settings, and they said they make people lie down on a gurney and get wheeled through the hall so they can see, that perspective that the patients see.
I think one thing that's important to remember is that even the most engaged patient, the best advocate, can, in a healthcare setting, feel less confident. There's something about a healthcare setting, and I remember a time when my husband was in the hospital. He gets bladder stones, and so periodically he's got to go in and get them zapped. And So we'd been going to the same hospital and, had the same neurologist and had come to like a certain anesthesiologist. And so, we'd asked, could, Dr. Adams, whatever, be there for Stephen this time. And it was on the board when we got there. It was great. And then this other guy comes into the room and says, I'm your anesthesiologist, and we're going to use an epidural, whatever. And hadn't looked at the chart. And we said, well, excuse me, no, Stephen always gets what he gets because of so-and-so, and what happened to Dr. So-and-so? We said, well, now I'm doing it. And it got a little contentious. And he offered us the out, and I didn't take it. But then, after he'd left, I went up to the nurse's station and said, we don't want this guy. We want the person we were supposed to have. And it shocked me that I couldn't tell the guy to go to hell, right then and there. I had to, catch my breath, and the nurse said, yeah, he can be a difficult guy. But the point of the fact is, if I got caught like that, what about all the people who don't have the gumption and the big New York mouth that I have, and
So there's one more question in the front, and I'm afraid our time is up.
We're going to end on a bad note.
Oh, no, you have to get a question from Eva.
Well,
Okay,
this
well,
is about the Cleveland Clinic. It's just what you've just been talking about. I went to look up what FMD was to learn more about it. Cleveland Clinic's page came up, so I clicked on it. And while I'm reading, a chat window came up. So I clicked to chat so I could ask my question. And then I was stopped by a long list of information that was needed of me to proceed with the chat. My first name, my last name, my birth date, my zip code, and whether I was interested in this for myself or someone else. And I put for someone else. And then I got another long list. Now they want the first name, last name of the patient, the address of the patient, the birthday of the patient, etc. I get to the end of all that, and I type in my question, and I'm shown the Heart and Vascular Institute nurses are either helping others or you reached us after hours, please call back.
A busy signal.
And you can also contact us by online email by clicking here. Please, if it's a chat, don't ask us for all this. We just want to tell you maybe our first name and go to chat. Thank you.
That's a wonderful point.
Eva, one more question? Oh, back there.
Just real quickly, this whole conversation reminds me of the concept of user-centered design, which I don't know if you've heard of that, but essentially it's including those who are meant to use whatever product it is that you're designing in the design of the product. And it strikes me certainly that patients, consumers, caregivers can be incorporated in the design process of this brave new world. But it also strikes me that there's probably opportunity to engage both physicians and patients together in that kind of effort, because too often when we're talking about healthcare redesign or whatever it is we're talking about healthcare, physicians and patients are put at odds to each other, when in actuality that's the most natural relationship in all of healthcare. And the interests of physicians and their patients are really, for the most part, very much aligned if you remove all of the other clutter. And so my question to the group is, what are some specific examples of how you can take things like patient experience data or patient stories and actually put them into action? So it's one thing to collect the information, and that's great, it's a first step. But then if you collect the information but don't really know what to do with it and don't ever do anything with it, and then your patients don't see that you've used it, you could do more harm than good. So I think providers often struggle with this notion of, yeah, this is great information, but I have no clue what to do with it. So what are some specific examples of how to put that information into action?
Well, I can provide a really simple answer from an online reviews perspective. You're going to, as a provider, have feedback. You can respond to that feedback on those reviews so that people know you're hearing it. And it doesn't have to contain PHI, which is obviously inappropriate in a response. It is, thank you so much for providing feedback on my practice. We strive to provide a really great experience for our patients, and we'll continue to do so with your feedback, right? Something very simple that can be applied to both negative and positive feedback. So people hear that their voice matters. And you can also reach out to that patient directly and say, hey, I heard your feedback. I really am pleased you had a good experience with this and this and this, but I'm so sorry billing and administration was a problem in your visit. Tell me more about that. I want to make sure we improve that for you next time you come and for our practice on the whole. So there are a lot of opportunities to take, all the information that's coming to you and use it to take action that's appropriate. Now, this is really simple. In the Angie's List world, you're getting very specific pieces of feedback that, frankly, in most cases are actionable, or at least could warrant a pretty appropriate response to show that you're engaged. And just that goes a really long way with consumers and patients.
Sarah, one last word?
I would say that you don't have to know exactly what you're going to do with it. You have to be open to suggestions about what to do with it and rely on exactly the same people that you're asking for that information to help you in finding the end solutions. In healthcare, you've got a huge group of really intelligent people. In patients, you've got a huge group of intelligent people. Use the creativity, put those groups together, and have them say, now what we can do with this. And dream big. Dream big. Let anything be a possibility, and then start working down. Instead of looking at obstacles, look at opportunities.
There's one thing we did one time very quickly. We took a patient narrative, had that patient write down every person they came in contact with in the hospital. They wrote it down. We had a session where we asked every single caregiver on that list to come and had that patient and their caregiver share back their experience. It was probably one of the most powerful things I've ever seen, because it was reinforcing for the patient, it was reinforcing for all the care providers, and back to your central concept, which is there's a sanctity to that relationship. As we evolve these products, the more they can enhance that relationship, I think the more vital they will be.
In the patient safety movement, there's an expression, nothing about me without me. It goes beyond patient safety. It fits into the whole world of healthcare. And when you're talking about redesign, hey, nothing about me without me.
Good motto to remember. Thank you very much.